Anyway. Okay, yeah, at this point, you can also put a sensor, another sensor of this electromagnetic field which is created around the patient to get this kind of registration. You can attach the second sensor, for example, to the handle of your needle, to the handle of your electrode if you are performing radiofrequency, for example, as you see here. One sensor is applied to the ultrasound probe, and this allows to have this matching ultrasound and CT, ultrasound and MRI. The second sensor applied to the needle allows you to see the needle going into your target And what is marked here in green as a circle is the expected volume of necrosis for one single application of that particular electrode. I try to restart this video and stop immediately. Okay, this is an example of a lesion which is visible with CT, very small liver metastasis, entirely overlapped by this yellow dot put by ourselves to indicate where is the lesion. But this lesion is not visible for sonography because it's very small. Only with contrast agents and not always these lesions are visible so low. But we don't care. If the registration is done correctly and then you start introducing your needle, and the direction of the needle is okay, you reach your target and your eyes are here. Your hand is here guiding sonography, but your eyes are here. And you see that the lesion is entirely surrounded by the green circle representing the volume of necrosis which you will achieve when you start your radiofrequency machine. You can understand the big advantages of that. It's a totally different way of performing treatments or interventional procedures. Another case of a patient already treated 1 year before for this small metastasis, now a second metastasis, very close to the other one, not the same, it's not a local recurrence, it's a new lesion, but where is it for sonography? We don't know, absolutely no, invisible. But it's visible with MRI, much better than with CT. So we use MRI fused with sonography. This is the needle introduced, and when we start applying energy, you will see in a moment, you see gas here. Okay, this is gas forming, and you can see that this area corresponds very well to this area here, where the lesion is. If a lesion, for example, this case here, is best visible with diffusion-weighted MRI, we fuse ultrasound with diffusion-weighted MRI. I mentioned radiofrequency. We are using more and more extensively now microwaves instead of RF, especially for metastatic lesions. And you can fuse ultrasound and, in this case, CT, using microwaves. Different adapters, but you have to tell your machine, I am using now this kind of antenna with this kind of size, and the machine automatically gives you the possibility to see the antenna during the procedure. You can use the system with contrast-enhanced sonography. I don't know, probably here in Brazil, contrast ultrasound is not yet diffused. I heard some opinions about that. The one which is diffused in the World Sonoview by Bracco probably is not yet diffused in Brazil, if I know. I'm very sorry for you because contrast ultrasound is a new world, totally different from sonography. Anyway, you can also inject Sonoview during fusion to assess the correct position of your needle calculated with fusion. If you overlap this image over there, you find that the metastasis you are treating is exactly in the middle of the area of gas created by radiofrequency. So you have a double check by fusion and second check by contrast sonography. When you have to perform more than one insertion of your electrode, of your antenna, whatever, inside the lesion, because the lesion is too big, it's not so easy. I don't know how many of you are familiar with ablations here, but the larger the lesion is, the more difficult it is to treat. Because every time you have to move the needle from one part to the second part to the third part, you don't know where to go, because the gas created by your treatment masks completely your area. So the second, the third insertion are really very difficult. And sometimes you have to wait some minutes until gas disappears to reintroduce your needle. Using now this kind of systems, this kind of computer-guided system, this is no longer a problem. For example, big lesion, the volume in green is put before manually by the operator. You can also indicate in yellow the safety halo all around you like to treat in order to avoid possibly recurrences after treatment. Before starting the treatment, you can introduce with a computer into this mass here your green spheres. Each of them represents the expected amount of volume for that particular insertion in that particular place. So when you insert these spheres and you move your ultrasound probe before starting the treatment, for example, you see that this area here is not yet covered. So you need one more insertion here when you start the treatment. So before starting, you should know very well how many insertions are needed and where. It's no longer you yourself who decide, it's the machine that decides for you. So that when you start the treatment, you follow exactly what your pre-treatment planning has told you. First insertion here, gas forming. This area here is not yet treated, so you move back and you cover this area here. Again. Then you have all these areas are still blue. It means not yet treated. And you reinsert here. Look at the ultrasound image. It's absolutely useless. Just gas. But you don't care because your eyes are here. If registration has been performed okay, in a good way, you only trust this part of your image, no longer this one. Ultrasound remains your hand, just your arm. Your eyes are on the CT or in the MRI image. Typical example, hepatocellular carcinoma, not very small, I should say rather large, you see here. Insertion of the needle, first treatment. You see here, because there is no gas yet. So you start the treatment. You will cover this volume here. Gas is forming. We move back and treat the upper portion of this volume here. But this area remains red. This volume here remains red. It means not yet treated. But where should I go? Look at this image here. Nowhere. Impossible. But I know that this volume here is not yet treated. So I reintroduce the needle here into nothing, looking at sonography, into the liver, looking at CT. Can you see? I hope this can be comprehensible also to people who do not perform ablations. So you are completing your treatment in a totally blind way for ultrasound, but visible for your static modality, in this case CT.